Just before I start, I just want to have an idea since, I, I mean, are you all trainees, or most of you trainees, or is it a mix of, consultants and trainees over here?
Sir, I think everybody here is a trainee.
Okay, excellent. So let us, so what I'm going to talk about today is a subject that is often talked about, and in fact, this presentation in some form or the other you may have seen before. So we'll have since this is not a huge gathering, let us be a little more interactive. So don't hesitate to stop me in between and ask me questions, or write a question in the chat. I've kept the chat open. So I'm hoping that I will be able to, or just if Navneet can coordinate, then we can have a more interactive discussion, because often what happens is that speakers overshoot the time, and then there's not enough time to ask questions, etc. Okay, so I'm going to share my screen, and can all of you see?
Yes, sir, the screen is visible.
Okay. So prostate cancer radiotherapy is something that is, interesting in India, because it's not something that we, there's a high variability in how many prostate cancer patients we treat between different centers. Unlike, say, head and neck cancers or breast cancers or lung cancer, which is ubiquitous, prostate cancer patients are not commonly treated in all centers. In fact, when I was training in PGI Chandigarh, which is a big department, I can't remember treating too many patients with radical radiotherapy for prostate cancer. And I'm pretty sure that although it might be a bit better at the moment, it is still rare, or relatively rare, to treat a lot of patients with radical radiotherapy for prostate cancer in many of the teaching hospitals. And that is because the teaching hospitals are usually government centers. The patients who come to these hospitals are patients for whom urological symptoms are not priority. If they ever get diagnosed with prostate cancer, it's usually at a late stage, usually when they're metastatic. And therefore, you may, in your day-to-day lives, if you're all trainees, not see too many patients getting treated with radiotherapy for prostate cancer in the curative setting. And that's perfectly okay. When you finish your training, when you become consultants as faculty in centers, or as consultants in private hospitals, the scenario you will find may change a bit. But what is very important in terms of prostate cancer radiotherapy is that it is a very good example of how our understanding of the biology of cancer and the implementation of clinical trials to test the biology has actually led to a huge change in practice in the last couple of decades. So with this in context, let us start this discussion on hypofractionated radiotherapy for prostate cancer. Now, what are we going to discuss today? We are going to discuss the rationale for hypofractionation, the biological rationale, and the socioeconomic rationale. We are going to discuss the evidence for moderate hypofractionation and ultra hypofractionation, which some people call SBRT. And we are going to, in parallel, talk about our experience at Tata Medical Center in Kolkata in developing a program for hypofractionation. So what is hypofractionation all about? Now, we know, and all of you would learn in your radiobiology classes, if you are MD trainees or some of you may have learned it a few years back, because some of you may be, fellows or fellowship students or something. So usually the conventional fractionation in radiotherapy is 2 gray per fraction, 1.8 to 2 gray per fraction. And prostate cancer was also treated at 2 gray per fraction for the longest time. Okay. Now, because prostate cancers are not very radiosensitive, curative doses for prostate cancer are very high doses. Okay. So if you want to treat prostate cancer at 2 gray per fraction, you will have to give about 78 gray at 2 gray per fraction, that is 39 fractions. Now, if you consider your regular day-to-day practice, this is probably the highest curative dose that you give out of the SBRT setting. Okay. So that is 78 gray is not easy to give. 78 gray is a long treatment in 39 fractions. And because it is 78 gray, we are very concerned about the toxicity to the adjoining structures. So if the rectum gets 78 gray and the bladder gets 78 gray, then there is a significant chance of side effects. Which is why prostate cancer has been historically at the center of many of the advances in radiation oncology in the Western countries. In India, of course, prostate cancer treatments have only now picked up. But in Western countries, prostate cancer radiotherapy, because of the high doses required, has been central to the development of IMRT and has been central to the development of image-guided radiotherapy. The goal being that we need to reduce the dose to the rectum and bladder as much as possible. So 2 gray per fraction, long treatment, and advanced techniques is what the standard treatment of prostate cancer is. Now, we know now that 2 gray per fraction can be replaced by a higher dose per fraction. So we can change this treatment over 8 weeks to a treatment of 4 weeks. 60 gray in 20 fractions. Okay. And the question is that can you also replace this treatment with an even shorter treatment of 7 to 9 gray per fraction and 5 fractions, either delivered alternate days or delivered once a week. So we will look at how this is possible, what is the evidence, the biology behind it, and the evidence to back it up. Everything that we do in terms of looking at dose fractionation centers around the linear quadratic equation, or the biologically equivalent dose, which, as you know, comes with this formula. Now, the traditional understanding is that tumors are rapidly proliferating, and therefore their alpha beta is approximately 10. The normal tissue alpha beta is approximately 3. And to achieve the best balance between effect and toxicity, the conventional fractionation of 1.8 to 2 gray per fraction has been standard. But this understanding undergoes a reversal or undergoes a complete rethink if the tumor alpha beta is not different from the alpha beta of normal tissues. If the tumor alpha beta is around 3, or if the tumor alpha beta is less than 3, then this conventional fractionation really is no longer the correct way to treat patients. In fact, in prostate cancer, the alpha beta is understood to be close to 1.5, which is even less than the alpha beta of normal tissues. So what is the implication that this has on our treatment paradigm? Now, how did we first know that the alpha beta is not 10 and it is in fact so low? you know, about 2 decades back, Brenner is a very renowned radiobiologist. Brenner and Fowler, they published articles based on what? Based on high dose rate brachytherapy data. And what they were trying to do is they were trying to see that when you have patients who are treated with brachytherapy for prostate cancer, they are being treated at high doses per fraction. Now, what kind of dose with high dose rate brachytherapy equates to dose at 2 gray per fraction? And using this kind of data from actual patients and their outcomes, they postulated, based on their radiobiological calculation, that it is likely that the alpha beta of prostate cancer is going to be in the range of 1.5. Subsequently, large databases of patients treated with brachytherapy and external beam radiotherapy were looked at, and these databases showed a surprising, kind of concordance of data of the results, and the alpha beta for most of these, it would hover around 1.5 to 1.8. Some of these had large confidence intervals. 1.5 was, of course, a point estimate, right? So if you understand basics of statistics, you will know that it is never going to be exactly that. But what are the possibilities? It would be somewhere between, as you can see from the PowerPoint slide, that it would be somewhere between, say, 0.5 to 0.8 to about 2 to 3. Okay, if you average out. Now, every single analysis did not show the same alpha beta ratio. There were some outliers. For example, there was a study that was published by Soren Benzen, which showed that some people thought it was 8.3. There was a study published by Williams, which says it was 3.9. But the majority of studies were pointing towards a value of 1.5. Now, what does this imply? What significance does it have to our understanding of fractionation? So let us look at this graph, and first of all, let us look at the red lines. Okay, the red lines, the solid red line is the tumor. The dotted red line is the organ at risk. Now, if the alpha beta of the tumor was 10 and the alpha beta of the OAR was 3, then what would happen if the dose per fraction was increased from 2 gray per fraction to 3 gray per fraction to 5 gray per fraction, adjusting the doses such that I would keep the EQD2 of the tumor to be the same. Okay, more or less the same. If I did that, what would happen is that the tumor control probability would stay the same. But by increasing the dose per fraction, my normal tissue complication chances, or the EQD2 to the organs at risk, would increase. If alpha beta was 10 for the prostate cancer and alpha beta for the OAR was 3. But if the understanding is reversed and the alpha beta of prostate cancer is actually 1.5 and the alpha beta of the OAR is actually 3, then the opposite happens. As we increase the dose per fraction, if I keep the EQD2 of the prostate cancer dose to be the same, then by virtue of the fact that the alpha beta of the OAR is more than that of prostate cancer, the OAR doses will actually reduce. So the paradigm is reversed. When the alpha beta of a cancer is high and the alpha beta of the OAR is low, then we want to treat at 1.8 to 2 gray per fraction, because increasing the dose fractionation will mean increasing the normal tissue complications. But when it is the opposite, then treating at a higher dose per fraction is theoretically better in terms of normal tissue complications. So if you got this understanding, then you would realize that it's not just a question of the number of fractions and the cost, it is actually a question of radiobiology and normal tissue complications also, in order to understand, in order to appreciate the benefits of hypofractionation. Therefore, we can do two things. One is that we can keep the dose the same to the tumor and reduce the likelihood of normal tissue complications. Or if we wanted to be a bit ambitious, we could increase the dose to the prostate cancer and keep the normal tissue complications the same by doing hypofractionation. And that might actually improve outcomes in prostate cancer radiotherapy. But this is all in theory. The first thing that we need to understand is that this now needs to be proved with clinical data, because we know that the linear quadratic equation is, after all, a simple equation, and it is a theoretical equation. Unless we have clinical proof, we cannot really consider hypofractionation to be the better alternative in prostate cancer. So should we hypofractionate in a country like ours? Okay, so is there a need to hypofractionate? Is there enough data? Is there enough experience in India? Is is hypofractionation something we should do in only in special situations like the pandemic? So let us look at this question and see the rationale, the socio-economic rationale. So why should we consider hypofractionation in India? If you look at our situation, our radiotherapy machines are fewer, our patients are more. Patients often have to travel long distances. They have to, the cost of treatments are high. They have to spend money staying near the hospital, etc. For the hospitals also, it's a question of managing their resources. If they could treat more patients within the same time slots, then it would be much better for the hospital. So there is actually, this is not just a fancy idea for Western countries. Hyperfractionation would be something that would be extremely, extremely relevant for a country like India. So if you could do it with enough radiobiological rationale and enough clinical rationale, enough evidence, then it would be something that would benefit us a lot. So the first question that we are going to ask is that, is there enough clinical evidence for moderate hypofractionation? Now, what is moderate hypofractionation? Moderate hypofractionation is usually hypofractionation that is less, between 2.5 to 4 gray per fraction. Okay, this is just a ballpark figure, but most trials use this number to define the bounds of moderate hypofractionation. Now let us see what are the timelines of how the clinical trials evolved over time. Okay, so there are 6 randomized control trials which have looked at moderate hypofractionation versus standard fractionation in prostate cancer radiotherapy. And these trials, and this is the the dates are the dates when they were reported, when they reported their clinical outcomes. And as you can see, these trials started in the early part of the 2000s, soon after this data, radiobiological data started coming out. So the first one to publish was the Italian study, which we are going to see the summary of these studies. Then we have the the really large CHIP trial, whose safety data came out in late 2011. We have the Fox Chase study. We have the CHIP and final results, the Hypro study and the Profit study. So we have all this data and the RTOG 0415. So there are 6 randomized trials that have compared moderate hypofractionation versus standard fractionation. Now let us look at a summary of these studies and what are the kinds of patients that they treated. So the Italian study compared 80 gray in 40 fractions versus 62 gray in 20 fractions in high risk patients only. Okay. The Fox Chase, this was a single center study published from Italy. The Fox Chase Cancer Center published second, comparing 76 gray in 38 fractions versus 70.2 gray in 26 fractions in intermediate and high risk patients. The RTOG 0415 study compared 73 gray versus 70 gray in 28 fractions in low risk patients. The CHIP study, which is the largest of them, with more than 3,000, close to 3,000 patients, more than 3,000 patients, they looked at 74 gray in 37 fractions versus 57 gray in 19 fractions or 60 gray in 20. There are 3 arms. And the majority were intermediate risk patients, but some were low risk and some were high risk. The PROPHET study in Canada compared 78 gray in 39 fractions versus 60 gray in 20 fractions in 1,200 patients of intermediate risk disease. And the HYPRO study compared 78 gray versus 64.6 gray in 19 fractions in intermediate and high risk disease. So if you look at this summary, you will realize that the majority of patients who have received moderate hypofractionation are about 4,000 patients in intermediate risk disease, about equal numbers in low risk and high risk disease, and 500 patients were the high Gleason score patients. Why have I kept this separately? Is because there's this thing that does high Gleason grade have a different alpha beta ratio? Okay. So I just wanted to summarize it in my own mind as to how many, just for my own understanding also, how many patients in these trials were Gleason grade 4 or 5. And these are the results. Now, you have to understand that all these studies did not have the same primary endpoints. Some of these studies were designed for better outcomes with radiotherapy in terms of biochemical control. Some other studies were, the majority of them were, however, non-inferiority trials. Non-inferiority trials basically check whether a simpler treatment, in this case, a treatment with less number of fractions, is non-inferior to, not equal to, not inferior to the standard of care, which is 2 gray per fraction. Okay. So the outcomes, the primary outcomes are given over here. And these trials, what they did was they all showed that there was no harm in doing moderate hypofractionation. In terms of biochemical control, the Italian study actually had better outcomes with moderate hypofractionation. The other studies showed that the outcomes were similar. In the CHIP study, the 57 gray 19 fraction arm had slightly inferior outcomes, so it couldn't be said to be equal to 74 gray 37 fractions. But the 60 gray 20 fractions was non-inferior to the standard treatment. So you have 6 randomized control trials published over nearly 8-9 years that have now established moderate hypofractionation as a treatment that is not inferior to the standard treatment, standard fractionation radiotherapy, and has the advantage of less number of fractions. So moderate hypofractionation can be safely considered as non-inferior. Now, what about toxicity? When we are increasing the dose per fraction, obviously we are concerned about the toxicity also. Now, what did the toxicity results show? The toxicity results were slightly different from expected. In the graph that I showed you, we found that if I increase, if I change to 3 gray per fraction, I should get slightly less toxicity, isn't it? If I kept the EQD to the same. But the toxicity results of the studies did not show that the toxicity was less. They showed that the toxicity was more or less equal. There was one study where the GU toxicity was and GI toxicity was slightly higher in the moderate hypofractionation group. In the PROPHET study, it was slightly less in the GI grade 2 toxicity, but overall, they are more or less the same. Now, what does this mean? This means that we actually have to understand, just as we have a better understanding of the alpha beta of the prostate cancer, we really have to have a better understanding of the alpha beta of the normal tissues. We cannot just assume that it is 3. Maybe it is slightly less than 3. If it is slightly less than 3, then this would be much better explained, these results. But we are not getting into that today. So what about our experience in Tata Medical Center of doing moderate hypofractionation? This is the timeline of the studies that came out, but we, Tata Medical Center started treating patients in 2011. Okay, we are a relatively new hospital. So 10 years back, when we started treating patients, we started right away with hypofractionated radiotherapy. The reason is that at that time, there was a lot of buzz about this, and we had the Italian study which had come out, and we also had about the same time the chip safety data which came out. And so we were pretty sure that this was going to be the treatment of the future. So we, as safely and as cautiously as possible, we started treating patients with moderate hyperfractionation. So between May 2011 to the end of last year, we've treated 630 patients with radical radiotherapy with moderate hyperfractionation. That is a large number of patients. The first 18 patients, I said we started safely, and the goal was that we shouldn't, overdo things in our excitement. So instead of, jumping to the dose that everybody else was treating, we started with a slightly lower dose of 65 gray in 25 fractions in 5 weeks with an EQD2 of 76 gray. But once these patients were treated, by that time, the CHIP trial safety results had come out, and the CHIP trial was mainly testing 60 gray and 20 gray, although this was a 3-arm study, but the basic goal was to really test 16-20. Okay, and the EQD2 for 16-20, assuming alpha beta 1.5, was 77.1 gray, which was close to 78 gray. So we felt that this was the correct dose to use. So 60 gray in 20 fractions in 4 weeks became our standard fractionation. Now, all of these treatments don't come, in isolation. You have to figure out a lot of things when you start treating patients with a new fractionation schedule. Okay, the first is that what kind of image guidance should be used. So, in fact, one of our first studies was to test whether we needed to do daily online imaging for prostate cancer. And IGRT for prostate cancer is itself a very big topic. But just to summarize, the only way to treat prostate cancer correctly with high dose radiotherapy is to do daily image guidance. Okay, you cannot give good quality radiotherapy or good quality IMRT for prostate cancer if you don't do daily image guidance. So our study proved that. Our study in our own patients, looking at retrospectively at data that we had collected, showed that daily online image guidance is extremely important. The second and more important question was that how should we set our dose constraints? When we started, all these studies had not published their results. They were only starting out. The publications were only just coming in. So we had to think of our own dose constraints. And what policy did we follow? We took the contact dose constraints, which are meant to be at 2 gray per fraction. And then we reduced them by around 40%. And then we kind of use the linear quadratic equation and an alpha beta of 3 to find out the dose that would be equivalent to these doses. Okay, so this is the EQD2 at 3 gray per fraction with an alpha beta of 3. So this 59 gray is equal to 70 gray, 56 gray is equal to 65 gray, 53 gray is equal to 60 gray, etc., etc. The contact constraints for these doses was this. We reduced it further, and we found that they were really easy to achieve. So we found that we could keep our mean doses well within the dose constraints that we had set which seemed safe enough because it was we could achieve doses which were much less than the context dose. And then we also started looking at our toxicities. And one of my colleagues, Dr. Moses Arun Singh, while he was doing his fellowship at Tata Medical Center, he looked at the data of the first 101 patients on hypofractionated treatment, and we found that our acute grade 2 toxicity was about 20.8%. Our grade 2 GU acute toxicity was about 7%. We did not have any grade 3, grade 4 toxicity. And we looked at the dosimetric correlates, and we found that there were some dosimetric correlates to the acute toxicities in patients. And these were not the percentage doses, but actually the absolute volumes, not the percentage volumes, but the absolute volumes. So we found some cutoffs using ROC curves, and we published our results in medical dosimetry a few years back. So these are the current dose constraints that we use for the 16, 20, 60 grain 20 fractions. For the target volumes, the PTV 60, CTV 60, and these are the elective nodal volumes. These are our constraints. We want to keep we want to cover our targets very well. And these are in our anorectum constraints and the bladder constraints. We also have constraints for the femoral bowel bag, the femoral heads, the penile bulb, and the external genitalia. Now, those were the early results. So we now have long-term results of the first 100 patients we treated with high-risk disease. We've audited our results of patients with high-risk prostate cancer with more than 5-year median follow-up. And our biochemical relapse-free survival is quite good. It is around 85% at 3 years and around 80% at 5 years, which is at par with any other reports. You have to understand that there are not many reports of moderate hypofractionation in high-risk prostate cancer. Okay, only 2 or 3 reports. And these are at par with those reports. The predictors of outcomes are Gleason score, the duration of androgen deprivation, and the toxicities are also at par with reported literature. But interestingly, we found that patients who had a prior TURP, a transurethral resection, because of urinary symptoms, had higher grade 2 toxicity than those who did not. Now, understand that this does not mean that you cannot do hyperfractionation in TURP patients. Okay, it just means that TURP patients are at greater risk of toxicity. They are probably at greater risk of toxicity even with conventional fractionation. So this is not a comparison of conventional versus hypofractionation, but just to show that TURP predicts for higher toxicity, probably because these patients are already compromised in terms of their urinary symptoms, and they have had an intervention, and this complicates matters further as time goes by. We also looked at our data of moderately hyperfractionated radiotherapy in node-positive prostate cancer, again, which very few reports are there in literature. Okay, and we found in the first 61 node-positive patients, we found that our 4-year results were around 77%. Overall survival was very good, and most of the patients had, metastatic failure. So let's move on to ultra hypofractionated radiotherapy. Ultra hypofractionated radiotherapy is also known as stereotactic radiotherapy. Now, this is an interesting nomenclature, stereotactic radiotherapy. Because you are trainees, I just want to bring to your attention that you have to really understand the root of the word stereotactic radiotherapy. What do you mean by stereotactic radiotherapy? Stereotactic radiotherapy is a word that started out with stereotactic radiosurgery that was used many years back. And what is the meaning of stereotactic? It means that I'm going to use a coordinate system to locate the exact position of my target. And how is this coordinate system defined? For brain tumors, this coordinate system was defined by the SRS head frame. Okay, so that is where the term stereotaxy started. You know, when neurosurgeons do a stereotactic biopsy, where on the OT table they can't see the tumor from outside, so they use a coordinate system from the imaging to find out where they need to, in which angle they need to put in their biopsy needle to get the biopsy from the right region. Now, however, this term was confused later on to mean to connote for radiotherapy at high dose per fraction. Whereas in modern times, most of the radiotherapy at high dose per fraction does not have any stereotactic localization. Our localization systems are exactly the same as regular IMRT with frequent image guidance. Okay, we do not use stereotaxy. Unfortunately, these two terms have been confused with each other, but we keep using it. When I give my lectures, I say, what is my experience with SBRT in prostate cancer? Whereas prostate cancer is radiotherapy at high doses per fraction is absolutely not stereotactic radiotherapy. Okay, it's IMRT delivered with daily image guidance. Okay, that is how it is. So the correct term to use is ultra hypofractionated radiotherapy. Now, ultra hyperfractionated radiotherapy, which was called SBRT because of the marketing of some companies, namely the SRS companies and also of CyberKnife, which use this nomenclature quite left, right, and center, I would say. So most of the initial experience of stereotactic radiotherapy or ultra hyperfractionated radiotherapy for prostate cancer came from centers which were using CyberKnife to treat the patients. And you know that CyberKnife is a very advanced machine which can track tumors and deliver very highly conformal radiotherapy from multiple planes and angles, which makes it gives it the ability to be very, very highly conformal. Okay, so most of the initial outcomes were 5 fractions of radiotherapy at around 7 to 7.25 gray per fraction. There are some studies which use a higher fractionation, but most of them were like that. So these were the initial studies on 20, 30, 40 patients. Many of these studies were published. And one of the leaders of this movement of stereotactic radiotherapy was a gentleman called Christopher King. Christopher King is a very nice gentleman who works in Los Angeles, in UCLA. Okay, so he is the guy who first spearheaded this movement of using stereotactic radiotherapy in prostate cancer. So most 7 gray per fraction into 5 fractions dose escalation has been tried later on. Most centers started out with low risk patients. Of course, when you start out these treatments, you have to start out in patients where you are unlikely to harm by giving less dose. Okay, because we didn't know the doses. How did we decide on 7 gray into 5? Okay, this was like many things in radiotherapy. This is an empirical experiment. The formula says it's okay, but we have to try it, right? So we don't want to try it in patients who are high risk of failure. The first experiments always have to be in the patients who are at low risk of failure. So most patients started out with low risk patients. Most studies initially use CyberKnife, but now there is widespread use of regular Linux for this kind of treatment. So Chris King collated data from a lot of these phase 2 studies and published results of the first 1100 patients who were treated with what was known as stereotactic radiotherapy. And he found that the results were excellent, absolutely. Okay, so if you look at the results, the biochemical control in low, intermediate, high risk patients are very good. And ADT in his analysis didn't really contribute to the results. Now the question is that how will you give these 5 fractions? Are you going to give them daily? So finish it off Monday to Friday. Or do you need more gap between fractions? Why do we need gap between fractions? Is because we need to give the normal tissue time to heal up. So if you look at, SBRT for lung cancer and SBRT for some other tumors, everywhere the standard is usually to give alternate day or 3 fractions a week. Okay, so King again, did a study on patients who were treated daily versus patients who were treated alternate days, and found that there was a lower incidence of late GI and GU side effects for alternate day treatment. Okay, so that became kind of the standard of treating patients. However, that was not the only way. And if you look at the first studies coming out from some countries like Canada, so some people in Canada also became started leading studies at that point, early on in the evolution of SBRT / ultra hyperfractionated radiotherapy. So, people like Andrew Loblaw, people like Glenn Bauman in Canada, they started leading studies, and the Canadian studies in low risk patients actually started using once a week radiotherapy. Okay, so their studies started using once a week radiotherapy. So the two common ways, the most common way was to give alternate day radiotherapy, but there were some studies which were once weekly radiotherapy as well. So what about our experience with ultra hypofractionated radiotherapy? Now, in 2013 odd, this SBRT pooled analysis came out. Okay, and we got really interested in looking at it because we were following because we had started doing moderate hypofractionation, we were following the evidence. So what we did was in 2013 we wrote a protocol to actually test SBRT as a prospective study in India, in not just low risk patients, but in all our patients. Okay, because there's no point doing a trial for low risk patients in India, we hardly get any. So we wrote a protocol to do a phase 1/2 prospective study of SBRT or ultra hyperfractionated radiotherapy in prostate cancer. And we started recruiting patients in 2014. So this is known as the SHORT study. SHORT is an acronym for short course hypofractionated once weekly radiation therapy for localized prostate cancer. And our goal was to test the safety and later on the biochemical outcomes, but mainly the safety of doing this. So we chose any localized prostate cancer, irrespective of the local stage. So it could be high risk, it could be locally advanced. All risk groups, as long as the PSA was less than 60. We chose to do 35 gray in 5 fractions once a week. Now, 35 gray in 5 fractions was an established dose or the most common dose when we started out. Later on, people have started giving slightly higher doses, but at that time, 35 and 5 was kind of one of the standards. And once weekly we chose because we wanted to be very safe. Safe when in the future you lead your own studies. It is very important to understand that our first commitment is towards the patient. And you must take the patient's safety into account first before you try anything fancy. So our goal was to make sure that this fractionation was safe. And we were going to use IMRT rapid arc because that is what most people in India could use. There's no point designing a study with some really ultra fancy technique that nobody else can follow. What was very unique about our study was we started treating elective nodal radiotherapy in high-risk patients. And we chose a dose of 25 gray in 5 fractions to be given simultaneously. And we would do image guidance daily with CBCT before and after treatment. And our primary outcomes was acute toxicity, secondary outcomes were late toxicity, biochemical control, and quality of life. This was a phase 1-2 study. So the main goal was to prove that it was safe. And we planned to recruit 30 patients. And it took us 2 years actually to recruit 30 patients because this was an experimental study, right? So when we told our patients that, you know, we are going to change your treatment from 20 fractions to 5 fractions, and if you explain your study well, not everybody will come and join your study. But we finished our accrual in February 2016. So our goal was to treat 35 grain 5 fractions once a week, check the acute toxicity weekly. Our androgen deprivation schedule was for low risk nothing, intermediate risk 6 months, high risk 24 months. We would follow up our patients 3 monthly for 2 years and then 6 monthly. And we would do PSA clinical late toxicity assessments, and we would also look at their quality of life. Now, again, we had to find out dose constraints for our OARs. Okay, there weren't any that were established dose constraints, especially when, you know, we are treating patients with higher risk disease. Many of them have their seminal vesicles involved, so there would be lower, you know, higher dose to the rectum and bladder. We were treating elective nodes. So we formulated dose constraints more or less in the same way that we did for moderate hyperfractionation, looking at quantic constraints and then reducing it further. And in any clinical trial, you have to set your dose constraints, set your quality benchmarks very clearly so that you give quality treatment during a clinical trial. Yeah, so these I've already talked to you. This is prostate plus elective nodal radiotherapy, VMAT treatment planning, once weekly fractionation, and we did not use implanted fiducials. We did daily CBCT before and after. Now, before we go to the results of this study, let us see how the, you know, we took 2 years to recruit, another 4 years follow up before we reported. So in between, what happened to stereotactic or ultra hyperfractionated radiotherapy? The most important thing that was tried was dose escalation. So people started checking whether we would increase the dose from around 35 grain 5 fractions to how much more can we give. So people in this particular, you know, those escalation studies began to get performed, and Robert Timmerman, whom you must have heard the name of, he's the, you know, leader of stereotactic radiotherapy studies and especially lung cancer studies. So Robert Timmerman and his colleagues did a dose escalation study, where they increased dose from 7 gray per fraction to 10 gray per fraction. And what they found was that up to 9 gray per fraction, it was perfectly safe. But at 10 gray per fraction, there was unacceptable toxicities. A lot of patients required colostomy, etc., etc. We won't go into the details because we have to finish on time. But this study showed that we cannot exceed 9 gray per fraction, 5 fractions for prostate cancer, ultra hyperfractionated radiotherapy. 2 other studies had also reported some results in between. Okay, the first was the Hypo-RTPC study, which was a large randomized control trial. It was not a trial of stereotactic radiotherapy. They used regular 3D CRT IMRT of patients who were intermediate risk or low risk, and you know, actually intermediate risk is the right term to use. Intermediate risk patients, 78 gray and 39 fractions versus 42.7 gray in 7 fractions, that is 6.1 gray per fraction, 3 fractions a week. And in this randomized phase 2 study, the estimated failure-free survival was 84% in both treatment groups. And there was no difference in physician-reported acute or late toxicities. There were higher patient-reported acute toxicity in ultra hyperfractionated radiotherapy, but not in late toxicity. The second study, which has not reported its final outcomes, but has reported its acute toxicity outcomes, is the large PACE-B randomized control trial in the UK. This is again in low intermediate risk patients. and compare 78 grain 39 fractions or 62 grain 20 fractions versus 36.25 and 5 fractions. So if you look at their acute toxicity results, you will find that the grade 2 toxicities, acute grade 2 toxicities, GI and GU, are the same. So, ultra hypofractionated radiotherapy is same, is not more, the safety of ultra hypofractionated radiotherapy has been confirmed, at least in the acute toxicity levels in large randomized control trials. So let's get back to us. So we started in 2014. The hypo-RTPC and the PACE-P safety was presented in 2019. And right about the same time, we published our results of the TMC short study. So this study came into print earlier this year. We recruited our 30 patients. As you can see, most patients were, Gleason 3+4 or 4+3. The median Gleason score was 7. The PSA, the median PSA at diagnosis was 17. The T stage, most patients were T3A or B. And if you see the NCC and risk groups, then about 2/3 were high or very high risk patients. We could meet all our dose constraints, and the acute and late toxicities were quite low. So we achieved our main goal of proving that this kind of dose fractionation can be safely given in prostate cancers that we see in our setting. We looked at the quality of life, and we found that there was only a temporary worsening of urinary symptoms at the end of radiotherapy, but otherwise the urinary symptoms came quickly back to baseline. Okay, and there was no difference or no worsening of any other symptoms during the treatment. It was actually a very, very, very well tolerated regimen. This is the IPSS scores. The IPSS is a patient-reported symptom score that we use for prostate cancer. And you can see that even for the patients who had high IPSS scores to start with, and were usually not considered good candidates for ultra hypofractionated radiotherapy, even these patients, their IPSS scores increased at the end of RT, but then came down again. Okay. So in terms of disease control, with a median follow-up of more than 3.5 years, we had one patient with biochemical failure at 10 months. So the 3-year biochemical control, clinical control, was 96.7% at 3 years and 87 or 88% at 4 years. One patient died of COPD exacerbation unrelated to prostate cancer at 14 months. The 4-year overall survival was 96.7%. Now, when we compare our toxicities with other toxicity reported from other studies which have done once a week fractionation with SBRT, these are the other studies which have reported, and our toxicities were very good. Okay. Now, we are not the only, obviously, hospital in India which is doing SBRT. So the Tata Memorial Hospital has a long history of the use of moderate hypofractionation, and Dr. Vedang Murthy's team is leading, several initiatives in this area. So they have published their initial experience. This does not have long-term data. This has only acute data with a median follow-up of 18 months. And they have treated 68 patients with high risk, very high risk, and node-positive prostate cancer. And their early results are also very encouraging. Okay, with more follow-up, we will probably know that long-term data in a few years. Meanwhile, another study looked at comparing alternate day ultra hyperfractionated versus once a week hyperfractionated. Okay, and this is an important thing because, as I said, in Canada, many studies were using once a week fractionation. So this is actually a Canadian study which compares once a week versus alternate day. And they found that once a week fractionation had better quality of life outcomes in the acute setting in the bowel domain, fewer moderate severe problems in the bowel QL during the acute period, and better acute urinary quality of life. Okay, so we know that once a week radiotherapy with ultra hypofractionation is slightly less toxic than alternate day radiotherapy. With this background, Tata Memorial Hospital in Mumbai started a large randomized control trial called the PRIME trial in high-risk node-positive prostate cancer, randomizing patients to 68 grain 25 and 5 week, which is their moderate hyperfractionation schedule, versus 36.25 gray 5 fractions alternate days. Okay, and we joined their study with our standard fractionation schedule of once a week radiotherapy in and slightly different moderate hyperfractionation schedule. Okay, because we were used to giving 20 fractions and not 25 fractions. So in the next 5-6 years, we hope to give you an answer to this question of whether, you know, ultra hyperfractionated radiotherapy is likely to become standard of care in the patients that we usually treat, which is high risk or node positive patients. And this is a very important study because it really looks at the problems we face. And this study, we are really hoping, will give us the answer, which may, if it turns out to be equivalent, if it turns out to be non-inferior, we will be able to change our treatment paradigm in India considerably. Therefore, to conclude, hyperfractionated radiotherapy has a very strong radiobiological clinical basis. Moderate hyperfractionation is now considered standard of care in all risk groups, and there's evidence of safety and efficacy in node-positive patients as well. With ultra hyperfractionated radiotherapy, we have a lot of phase 2 studies which are very positive. We have phase 3 safety data in low and intermediate risk patients in the PACE-P study. We have our prospective phase 1-2 safety and efficacy data in high risk patients. And we are now doing a large randomized control trial. And the reason why we are talking about hyperfractionation more and more because of the pandemic, etc., but eventually this is likely to become a standard of care for all patients. Thank you very much. Happy to take any questions. Yeah.
Thank you so much, sir. It was indeed a wonderful talk, and I must say a mesmerizing talk. And so I request everyone, if there are any questions, you can unmute and ask, or maybe you can also use the chat box.
So one question that has come up is that, is there an alternative to daily CBCT? Well, let me put it this way. Let me ask you a question back. What kind of image guidance do you have? Do you have CBCT or you don't have CBCT? This is a question from Basala. No CBCT. So do you have 2D imaging? Okay. So if you have 2D imaging, then the correct alternative to daily CBCT is to put in fiducial markers and do marker match on 2D imaging. This is in fact, putting in fiducial markers and doing a marker match is actually the standard image guidance for prostate cancer. Okay, CBCT is being increasingly used and we use it in India a lot, but that is not the absolute standard. If in any non-India exam you are asked how will you do image guidance for prostate cancer, then the answer to that question is that I will insert fiducial markers and I will do marker match on a daily basis. Okay. If you can't do that, then you have certain disadvantages. Okay, because doing a 2D match without any implanted fiducials will just do a bone match, and the bone does not correlate with the prostate position at all. On a daily basis, the prostate position will be slightly different based on rectum and bladder filling. So if you do not have the capacity to do fiducial placement and daily imaging, then the only thing that you can do is increase your PTV margins to at least 1 centimeter, if not more, or 1.2 centimeters. And then you will face a problem of slightly higher toxicity if you want to give doses which are high. So you have to keep that in mind.
Sir, what is the rationale of doing CBCT after treatment? And if we do one CBCT before treatment and after treatment throughout the course of the treatment, won't it increase the radiation exposure to the patient?
We are not doing CBCT after treatment on a routine basis. We were doing it as a part of the trial of stereotactic. See, when you're doing stereotactic radiotherapy and you're not using fiducial markers and you're not then there is a small possibility that the prostate has moved in between. See, there have been studies which have shown that there is some intrafraction motion of the prostate. And traditionally, what has happened is that the prostate cancer stereotactic radiotherapy evolved in the cyberknife paradigm. Now, if you have any idea about cyberknife treatments, you will know that cyberknife treatments usually take a long time. Okay, giving 7 gray or 8 gray per fraction in prostate cancer with cyberknife treatment traditionally used to take about 40-45 minutes. I'm sure that the more modern cyberknife treatments are much shorter. But over a course of, even if it's say 15-20 minutes, giving this treatment over this period of time means that the patient or the organ would have moved. So cyberknife treatments are always accompanied by continuous imaging. So every few seconds, there is a verification of position. Now, when you translate that to a LINAC-based setting, you will have to prove to everybody that your prostate didn't move. Okay, we were not doing imaging while the treatment was being given. Now, because we are using rapid arc treatments, the treatments take hardly 3 minutes, 4 minutes to finish. So the chance of the prostate movement is less, but still in a study when you're doing it, you have to verify it just to at least convince yourself that what you think is true is true. So we actually looked at the pre and post shifts and determined that in only 2% of the fractions that were delivered was there a movement of more than 3 millimeters from the initial position. Okay, so we could convince ourselves that there was no. Now, there's obviously no point doing a scan after your treatment in the clinical standpoint. So the alternative is that if you're going to give 2 or 3 arcs in stereotactic radiotherapy with rapid arc or with VMAT, you could image before each arc. But each imaging will also take its own time and so may offset the benefits of doing the imaging in the first place. So if you've got only a 3-4 minute treatment, you might as well do the imaging and finish the treatment off. Okay, but if you want to be doubly sure, the more practical way to do it would be to image before each arc.
Thank you, sir. Any more questions?
Yeah. So when we are using nodal radiotherapy along with prostate RT, how do we take care of a mismatch in the CBCT? That's a good question. When we match the prostate, you can cause a mismatch in the nodal treatment. Okay. Now, we give more priority to the prostate gland when we are treating, you know, prostate cancer radiotherapy. So we accept the fact that we can cause a mismatch by matching the prostate, and we just go ahead with it. Okay, but your question is very intelligent, that there could be a mismatch, but here it's a question of what is more important. Okay, so when you're, say for example, treating head and neck radiotherapy, and you find that in order to treat the primary tumor, your neck nodal radiotherapy in the lower neck is shifting a little bit, you just have to ignore that, isn't it? Because there's no way you can match everything in complex anatomies. So if there are no further questions, I'd like to, thank Navneet. And I didn't put in a slide, but I wanted to talk to you about two things. One is, you might know that we have a fellowship program with IIT Kharagpur, which is a 3-year program post your MD or DNB. So that is a special program because it involves research with IIT Kharagpur on very innovative subjects. So if any of you or anybody you know are interested, applications are still open and you can apply for this year. The other thing I wanted to talk to you was about the FRCR program. So if any of you are interested in the FRCR exam, the part 1 course with Christie Hospital is due in the second week of January, and applications for the 7-day course, or the 6-day course rather, is open. You can visit our website, Tata Medical Center, and you can apply to join that course.
Okay. So thank you so much, sir. It was indeed a pleasure to learn from you, and we look forward to more learning from you. And I once again thank you for spending your precious time to educate us all. Thank you. Thank you so much,
Thank
sir.
you. Thanks a lot.